Test 1 2 3. Test 3 2 1.
Montgomery, you see my shirt?
I do. Thank you for sporting the colors. I got the other color, so we're
I
covered.
want to make sure you and I've got him covered today. and I'm down here. So
You guys just did that as we were going live on the air. So, Mr. Montgomery, this meeting is yours. Go for it.
Thank you, Mr. Mendenhall. And thank you, everyone, for joining us today. Welcome to episode 2, season 1 of the JPS budget process. When we last left our hero, I thought last session on Friday was, from my perspective, was really positive. I really enjoyed the presentations from the VPs, the major areas, major components of the organization, their challenges, what they anticipate being, what's going to be driving their request for funding in the budget. Those kinds of conversations, I think, are super valuable for us and for them. And so I really appreciated that. And I think today what we'll be seeing is, and Robert can elaborate more, and Sharon, of course, but is we're going to inch our way more into the numbers, not line item numbers. We're not there yet. That's going to be, again, the August meeting. But this is, again, the second step of the prelude into that full-blown August budget meeting. But hopefully to give you some context and to inform your thinking about some of the inputs to the budget. What are the supplemental funding inputs? What's the impact of the property tax? What are the impact of telehealth and MHMR and the jail and all those things that are really having significant impacts on our budget? What are those all about? And so give us a chance to hear those presentations or those discussions. And I invite you to ask any questions you possibly can. And I'll also submit at the end of this, there'll still be unanswered questions. And I just want to alert everybody, there's still going to be unanswered questions at the end of this. Some of those questions I would invite you to engage with Sharon or Robert between now and the budget meeting in August. If there's somewhere you really want to drill in and get some real specifics, I think they would invite that and welcome that. And then, of course, when we get to the budget meeting in August, that's when we look at specific numbers and funding items and have those discussions. So I just wanted to kind of preface this meeting with, there won't be a lot of line items. There's going to be a lot more numbers than we had before. And you're going to see a lot more numbers, but they're not going to be necessarily what we're spending on a specific line item. We're not there yet. But so with that having said, Robert, is there anything you would like to add to that?
Steve, a couple things. Karen and I and Sharon are here at the OPC, so we'll be able to run down some data or anything that y'all might need. To emphasize Steve's comments, which I appreciate, Mr. Chairman, is we're trying to get you all as board members the understanding of the process of where we are with finance. And with that, we as a staff can't make recommendations to you unless we know some of the aspects of what's going on with federal reimbursement dollars or what's going on with our ad valorem taxes. So we haven't gotten to the point of saying, here is the exact budget for you, and we're really prepared to discuss it piece by piece. There still is input that's needed from you all as board members, but we're going to give you an outline of a few of those key components, such as what is our stimulus money funding been, so you can put those in the buckets. Look at what the impacts of telehealth, which has been so instrumental in both its benefit and its financial strain. It comes as a dual sword to us. So the other thing I did want to mention to you all is we do, as staff, very much enjoy being with you. We have been with you a lot lately, and we appreciate that. The challenge that we have, though, is getting data and information out to you quickly. Because if you consider the fact that last week we had our budget workshop, and then we had a finance committee meeting, and then we had our HR committee meeting, and we have this budget workshop, it's been hard to generate all the information and get that out to you in a timely way. So you all got information today as basically giving you the ability to follow along with some of the things that Sharon is saying, and also give you the ability after this meeting to actually have the hard copy of it. We just did not have an ability to have you get that information for 4 and 5 days and be able to deliberate over it. And it's really not that. It's more of a dialogue at this point, at this stage anyway. So that's what we wanted to do and help you all out. I want to, on behalf of the staff, thank you, Mr. Montgomery, for helping us put this together and the role that you played. And Dr. Weber, thank you for allowing us to do this. I think that this could be a good model for the future for us as we try to figure out when we ultimately get to August and we're looking at a budget in hopes of helping you board members as much as possible and helping us as staff get this down. I see you have a friend, Mr. Montgomery. Very, very, very nice. So
This is, by the way.
Which one is that one?
Jake.
Okay.
Yeah.
And
Yeah.
it's one of two of the Blues Brothers, if I'm
Correct.
not mistaken. Dr. Weber, before we get into any of the comments that Sharon might have, is there any comments that you would like to make or anything that you would like to say that you might find helpful or you would like to see?
No, sir. I think you and Steve have covered it very well. Let's get on with it.
Super. Okay, we are going to turn it over to Sharon. Our hopes is that we will. Yes, sir, Pastor.
I'm sorry. Just
No.
one question before we get started. So, and I should have asked this last week, but what we received last week, what we're going to receive today, are we more looking at more of a present tense package, more than looking toward the future based on the COVID pandemic situation that we're in? I don't. It's tough for me to see that we can talk about 22, 23 on based on where we are now.
You're right. And it is more of an immediacy to this budget, and it's hard to project out. You will see today reservations made for what we think, and you all discussed this last week. We've discussed it amongst the staff, what we think we're going to see in potential connection increases, how to calculate unemployment. Really, it is pretty much reactionary to what COVID-19 is, but also we're still running a health network and we're still trying to make sure that our clinics run properly. And, you know, the fact that we were certified as a stroke center last week is an emphasis to us that strokes still happen and heart attacks still happen and trauma still happen. So there's two forms of this, Reverend. There is the actual sort of, this is the everyday work. Then there's the layered on COVID portion of that. And then there's the questions that we have going forward regarding COVID. So I think that will help you as you go through the deal today. Sharon is going to probably be finishing up at about 8:30, 9 o'clock tonight. So if you all could relax and get prepared. Yeah, Reverend's getting up and leaving. He didn't adjust himself in the chair. He's just going to get up and leave. So no, Sharon will not do that for her sake or y'all's sake. So without any further questions, Sharon, we'll turn it over to you. Thanks.
Good afternoon. Yeah, if y'all are going past about 5:30, I will not be here, so should be a quick wrap up. Y'all all have the presentation, but we're going to pull it up on the screen right now, and I'm going to go through that. This is probably not a presentation that would have been easy to have gone through on your own. It is more of a conversation, at least that was my intention. I'm not going to read to you the presentation, but I think it'll bring up a lot of the major changes from our projection and maybe what's happening in 20 that, Reverend Emerson, to your point, is a little bit different than we usually experience. And then what changes might be larger in fiscal year 21. So kind of give you a preview of some of those major variances that we'll be covering on the 13th. So hopefully we'll be able to condense that discussion from last week and today. So it'll be should be a nice segue. So Steve's already kind of talked to you about what we're planning on covering today. And these are, again, significant impacts either to fiscal year 20 or 21. Probably the most pervasive change in the way that we are providing care in the last 4 or 5 months is telehealth. Sometime in March, we realized that scheduled patients in the clinics would not have access to care, prescription refills, general questions, wellness checks. And so we very swiftly reacted and started to reach out via telephone to those scheduled patients so that we could help them through what we didn't know the time frame. We still don't know the time frame. It took us about a month before we could stand up a video platform for telehealth. We had that in the works, but it was not scheduled to go live until much later in the calendar year. So it was a large effort, and we mobilized, and it was operational for the first call on April 15th. Now, on telehealth, the telehealth platform, we could accommodate the scheduled patients, and we also have a platform for urgent care or unscheduled visits as well. And perhaps you guys have experienced that type of visit. As we anticipate clinics slowly beginning to phase in for more face-to-face, we do in fiscal year 21 plan to offer video visits where they're possible. We are seeing on average about 5,600 patients through telehealth per week, or about 2,200 for the last month. Currently, about 25% of those were video calls and 75 were telephonic. And you're going to see on the next slide, we've kind of flip-flopped that for 21 as we've stood up that video platform. We are seeing primary visits, we're seeing specialty visits, as well as behavioral health clinic visits. Behavioral health is about 12% of the total. So if you look at this graph, what I'm trying to show here is the historical. The total column, the orange, the top part of that is the telephonic visits, about 75% of that total. And then the blue or bottom section is the audio video visits. And we're projecting to see just over 122,000 patients via these modems. So here's a graph for 21, and if you'll notice, the bars have kind of flipped, where we're having about 70% audio, the video, and 30% telephonic. So again, the video platform is fully functional right now, and but some of our patients do not have access to a video platform. So we are still projecting some telephone visits to occur. Now, we have, if you look at the total number of telehealth visits, this slide represents about 93,500 visits, and we are anticipating phasing back up those clinic hours, the provider scheduling, as well as, seeing those face-to-face more frequently. So we are projecting slight decline in the telehealth visits, but we'll accommodate those depending on the reopening. So some of the planning and development, I think it's really interesting just how huge this effort has been. We created a telehealth steering committee, and that was led by David Mendenhall and Dr. Jerry Henderson. I'm not going to read to you who is all on that team, but it includes physicians, IT, acclaim, nursing, community health, behavioral health. And this committee was tasked, and it's ongoing, to provide a long-range look for the implementation of telehealth as well as the further development. But it's not just those folks. There's other subject matter experts that are also consulted throughout this. The compliance aspect of it, provider and patient experience, the application of IT, as well as rev cycle and quality. And then there's 4 active work groups that also report up to this steering committee for inpatient, ambulatory, emergency area, as well as behavioral health. So with all of this information, the telehealth steering committee was the people responsible for making suggestions on what needs to be considered for budget 21. And when I present on August 13th, you'll be able to see some of the dollars that were dedicated. There is quite a, there is a financial impact for the implementation of telehealth, and it's substantial for the medical center. Currently, the medical center is able to bill a facility fee when the patients are actually seen by a provider in our clinic. With telehealth, traditionally, there's no facility fee, and temporarily, HHSC has allowed us to charge what they call a connection fee, which is a much reduced rate during this fiscal year, and it is temporary at this point. So although we thought it was going to end, yes.
I'm sorry to interrupt you. And that issue of the facility fee, roughly what is that? How much is that for us?
So the bottom section of that slide, it's almost $3 million for fiscal year 21.
I'm sorry, I didn't ask that. I didn't ask that correctly. Per case. So we're saying a connection fee.
So a connection fee on average is about $25, but that is about a third of the typical facility payment that we would have received.
So about $75 is your average facility fee.
Correct.
Okay.
And the facility fee includes some other charges that patients may receive. But yes, that's what our experience has been over the last few months.
So Sharon, is the $3 million, is that the delta, or is that what we expect to collect?
No, the $3 million would be a decline in collections because we have not budgeted in 21 to be able to collect that temporary connection fee.
Okay.
HHSC through Medicare and Medicaid allowed rural facilities to charge a connection fee for the cost of the telehealth if they're trying to get to an urban subject matter expert. During COVID, one of the concessions that was made is that, this is this slide for the medical center, we were able to charge for that connection fee for Medicare or Medicaid patients. And then the second concession related to telehealth is that the physician payment for a telehealth visit is about half to a third of what a normal face-to-face reimbursement is. So when we look at a claim on the next slide, they're also going to have a financial impact from the telehealth visits.
Sharon, I got a quick question, and I don't want to get off topic, but is a telehealth visit, does it take half the time of a face-to-face visit? Do we have any data to show that a doctor provider could make up for it in volume?
Yeah, anecdotally from the meetings that I've attended, It might be a bit more efficient from a provider because there's a lower left without being seen or no-show rate, but
Right.
it does take about the same amount of time for staff to set up the clinic visit in Epic, for them to actually see the patient virtually. So I think the big pickup in the productivity component for a physician is going to be that patients are more likely to show up for their appointment because of the ease of the telehealth right now.
Okay, thank you.
You bet.
Can I ask a question, Sharon, on the facility
ma'am.
fee? Just want to clarify something. That $3 million was the facility fee that we had collected from insurance companies, right? We charge a facility fee when connection come in, but this is money that insurance companies would have been paying us, right?
Medicare and Medicaid included.
Okay.
On the commercial plans, it really depends on the managed care contract, what we're receiving from commercial insurers.
Okay. But the mainly, that is where you are saying the revenue is going to be decreased from, is through those insurance companies, right?
Correct. Yes, ma'am.
Right. Thanks. Mm-hmm.
So when we talk about the overall patient revenue, net patient revenue budget on the 13th, you're going to see some of these numbers that we're talking about today in the variance explanation. So again, on the medical center, it's about a third of the typical collection that we are getting in fiscal year 20. Because of that HHSC concession, and it is temporary, we are not budgeting for that connection fee revenue. So it's a total loss of $2.8 million for JPS. But it does get our patients in to be seen. It does continue on with their primary care and their specialty follow-ups. The next slide here is the same financial impact analysis, but from the claim side. So when the providers see a video or audio telehealth visit, they too receive a much lower reimbursement than during a face-to-face visit. Now, a claim will continue to bill and collect that lower fee throughout budget 21. So, and then depending on how long HHSC extends this waiver, it could add $1 million or $1.5 million into budget 21, but we're being conservative. We don't have that information yet. One thing that did happen yesterday is HHSC announced that the public health emergency would be continued for an additional 90 days. We're just waiting to really find out how that impacts this payment, as well as some other benefits that we've been able to receive in 20 as a concession for the pandemic. So that is going to wrap up my comments on telehealth. Are there any questions? There was a lot going on from a reimbursement standpoint on that.
Sharon,
Do we have, and this may be a quick, sorry, go ahead. Go ahead.
I'm just curious, what have we paid out that wasn't budgeted to start up telehealth? I mean, what kind of impact did we have, and is any of this federal money, stimulus money, able to cover any of that?
It would be. We'll talk about the COVID relief funds here in a moment. Any added expense that we've had through this, it's not well defined, as we talked about yesterday during Finance Committee, as to what you can or cannot. But I think any expenses in the way that we are working through this with THA and other work groups, as well as our auditors, if it was in response to the pandemic, then we will be able to submit those for consideration. I will say that we have also applied for several grants. We have received a $500,000 grant that is helping offset some of the costs of the implementation. We did budget for telehealth this year. It just was not planned. We had to really accelerate the go live on the
Okay.
program.
All right.
Steve, did you have a question?
Yes, ma'am. And this may be more for Karen, and I don't mean to get off the budget piece of this, but from a patient experience, do we have any feedback in terms of, the positivity or negativity of this experience for our patients for telehealth?
Yeah, so actually there's been some, let me start my video here. Actually, there has been some recent information that we've received from Laura Burnside and her team regarding the patient experience on those patients who either had a telephonic or a telehealth visit. Interestingly enough, the telehealth visits, the audio and video visits, we did quite well with the patient experience. And I don't have those exact numbers, but I will get those for you. The telephonic was not as good as even the face-to-face or the telehealth, but the telehealth actually was a little better than our face-to-face. But I will get the most recent information for you.
Okay, that's great. Thank you.
Did that also include feedback from the current COVID patients that are under case management, or is that not part of this telehealth option?
Amanda, I'll have to get back to you. It usually does include every patient that has been discharged from here. That probably would be on the hospital side, since those patients were discharged from the hospital side. But we have started a COVID clinic, and they would be included in the survey, and we can filter those patients out to see what their experience has been.
Great, thank you.
So the next section that I had prepared remarks on is what's been happening with all the COVID relief funds that have come through. So the next slide actually shows some of the larger amounts and kind of in chronological order that they've come in. We've talked about quite a bit the 8.2 million that was in the first round or two of just general relief funds of the stimulus bill. We also have talked about the 49.5 million advanced funding from Medicare. That was more of a cash flow item, and we'll have to pay that back over time as we see Medicare patients in the next 6 months. Probably the next three, we have not spent a lot of time on as a committee. Hrsa came out with very early on a program where you could bill a positive COVID patient that was uninsured and receive a Medicare rate for that patient. It's a very complex submission process, but we have been able to receive about a $1.6 million patient payment, and you actually submit a bill much like you would to Medicare for that payment. And that was through mid-July. So the program for those submissions has ended, but we still have a few in the pipeline. And so that's not quite the final number, but it would be the majority of what we are going to be able to access through that program.
Aaron, what does Hrsa stand for?
It's Hrsa. It's the health. Oh gosh. I always look up my acronyms for you. But it is a government agency that does not typically manage anything through the Medicare reimbursement arena. So that's created some of the challenges as we go through Hrsa for that funding.
Okay, so we can look it up.
Yeah, I will. What does Hrsa stand for?
For Health Resources and Service Administration.
Well, there you go. DT is online.
So
So
I just wondered who it came from. Is that from the federal government? Who is that?
it is. It is a subset of HHS,
Okay,
Health and Human Service.
thank you. I could understand you, DT.
I will be online from now on into the future.
Okay. All right. If we stumble across another one, I'll ask you about it. So when you look at the last two items, these are very recent. So during July, this is actually the second round of these two pools of money. There was a safety net hospital payment that was considered early on, and the criteria around that, there were three criteria around your disproportionate share of Medicare and Medicaid patients and unfunded. It also had to do with a certain percentage for your profit margin and your participation in some other government programs. We did not make that cut, but there was a second round, and we received $34.8 million in July through that safety net hospital payment round 2. In a similar distribution, the high impact targeted areas that were paid back in April. Of course, the Dallas-Fort Worth area had not been significantly hard hit like places that you heard about in New York. And in a later pool of funds that were distributed for high impact, we were able to submit our COVID and our patients under investigation for consideration, and we were given a flat payment for each one of those cases. So that was an amazing payment that we got in July from those two programs. And you know, from our conversation,
That's a really good job. That's a really good job your team's doing, Sharon.
Thank you. Thank you. There is a bit of, you do have to really stay on top of these programs. And we're going to be talking about in some later slides, our uncompensated care submissions and how JPS was positively impacted, and that took a lot of work as well. But you know, DT, I did want to tell you, based on our conversations yesterday, the larger two payments that we received in July, they will reside on our balance sheet until closer to year end as we work through some of those calculations with some of our peers as well as our auditors.
That was a great briefing from BKD yesterday also as well. Thank you.
Thank you.
Are any of those funds in response to the grant group that we emergency funded?
The grant group that you're talking about is Guidehouse. And, you know, I will tell you that no fault of their own, they're probably not an expert on the COVID Relief Act funding. A lot of times the information that comes out, it's all very general. It's typically sent out with a Q&A, and you don't know how much you're going to receive or when you might receive it, or if you're even in the pool until the distributions start to occur. What Guidehouse has provided us some invaluable experience in is some of the FEMA or emergency funding that we will be filing before the end of the year, and how to gather that information, what support they will accept, and little pockets of dollars that we may not have even considered in our final submission. So we're still working with Guidehouse on that information. Guidehouse was also able to walk us through a full list of grant opportunities that had been extended And as we walked through those, we did identify several that we may qualify for, but those were already in the works. So again, their focus is mainly the FEMA submission and request for funding.
Okay, thank you.
You bet. On the next slide, Acclaim has benefited from these as a group of providers. They received $530,000 in April from the general stimulus package, and about $322,000 for the Medicare advance payment. So one of the largest components of our operating budget and revenue is supplemental funding. And we're talking about DISH, DSRIP, UC, and these are just tremendous benefits. And just as a reminder, the supplemental funding arises mainly because the state of Texas did not expand Medicaid 10 years ago. So these are typically for Medicaid or self-pay patients that do not have a payer source. And we all are aware of the formula funding and how negatively that has impacted JPS as people learn how to
game it.
If you want to call it that. You know, consultants get smarter. Institutions are able to figure out how to maximize reimbursement, and it is a zero-sum game. So, you know, one year we saw a huge increase in the ambulatory pool. Well, that pulled away from all of the hospital pools. And it just seemed like year after year, there were negative impacts. I've got a slide and a couple of slides that will help demonstrate that. But for the big news is that for the last 2 years, we have been preparing for a change in that formula. CMS worked with the Texas agency that distributes these funds, HHSC, to develop a new program. Historically, the hospitals would look at our below-cost Medicaid reimbursement as well as the self-pay population and what those cost us. And we would get, this is a very simple format, but we would get our percentage of the total pie based on our uncompensated care from those two populations. CMS stepped in and said, you know, we really just need you to consider people who have no insurance. So don't look at that Medicaid bucket. Let's look at just the self-pay. And we've got a great way to do that already through your cost reporting. We do it consistently, and every hospital does it nationwide. So for fiscal year 20, the distribution formula for UC went to pulling our self-pay costs off of our cost report as submitted 2 years ago for fiscal year 18. It's always a 2-year lag. So we have worked diligently over the last 2 to 3 years. And again, you as a board have also reviewed consistently our charity policy and how that information gets captured through the presumptive charity program that we presented about 6 or 8 months ago. And we were able to get a really large uptick. Now, it was expected that the Texas public hospitals would benefit greatly from this redistribution. The problem is that we were not positive what everyone else would look like. So you could measure yourself, but you could not measure what other people would be doing at the same time. And it's all based on a pro rata share of your total uncompensated care. The pool remains the same. So we were able this year to receive $144 million through the uncompensated care bucket. And I'm looking at the second column from the right, and the top section or gray area is what we're referring to UC. Those are some small numbers, but they're fairly significant. If you go back to fiscal year 2013, you can see our funding level for supplemental funding was at about 207 million. And year over year over year, it consistently declined to fiscal year 19 at 125 million. So we have increased because of that formula change, and we will continue that increase. And we'll talk about our numbers for budget 21 here in a moment. Does anybody have any questions about the formulary impacts of this, or what we've covered in the last slide? It's a lot of information, and it was a very large change. Okay. So we are expecting budget 21 to decrease from the current year level. Because of COVID, we were granted kind of a one-time relief from what the dollars are that we have to send up to receive the supplemental funding. And that provided us about a $13 million benefit in fiscal year 20 that we don't expect to receive in 21. And then because of the formula funding, and now everything's out on the table with filings, and will be one more year into the cost reporting aspect of it, we were a little conservative of what changes could potentially happen in that formula funding, and projected a decrease in that as well. So this slide is more of a summary. It's just the COVID-19 funds that we received that were not necessarily anticipated for fiscal year 20, and then the UC summary of the 94 million for 20 and the 63 million for 20. That somebody tried to FaceTime this iPad, which is not mine. Am I still alive, or am I frozen?
You're back. We lost you there for a few seconds.
Okay, my screen is showing my face is frozen, so I'll try not to look at that. It's not very flattering. So the 63 million is above and beyond the typical 50 million that we are able to, that we've historically received. It is really throwing me off. If y'all can't tell, you think I would be used to this by now, but it's just really getting to me. Now, again, you know, the UC funding is going to continue under the same formula for the foreseeable future. So it's very complex. And again, we are a bit conservative as we move into budget 21. So now I'm going to shift gears a bit into a different supplemental funding, which is our disproportionate share, or DISH, as we have called it. This program has been around for 30 years. And every year we talk about a change and a decrease of the legislatively approved federal amount for DISH. For fiscal year 20, we have received, or we're going to receive, about 10 million more than budget, because we thought the pool would decline about $100 million in total. That did not happen this year. It was waived, but we are not confident that will be waived again. So that's kind of a one-time pickup, if you will, for 20. There was also a shift in who qualified as a state-owned hospital. And for those that did not qualify, it provided more funds for the other pools within the DISH formula. So everybody benefited from that change. So for budget 21, we are expecting about a $10 million decrease from the projected 20 level because of that, the waiver that occurred for the decrease at the pool. Any questions on DISH? Okay. The third section of supplemental funding is DSRIP, and that's the Delivery System Reform Incentive Payment Program. And this was the state's answer to pay for performance. So we have a lot of metrics that we closely watch. It is a large payment, and we are projected in fiscal year 20 to receive about 13 million more than we did in the prior year. Because of COVID, the largest benefit was because of the federal matching percentage. What we were given a break on that. So that provided us 14 million more of net income than we expected to receive. And then we also received, we outperformed our metrics and we did better than we thought. So that provided us with an additional 6 million. So, and then as DSRIP matures, it's a declining pool, declining federal pool. So we're expecting to receive about 7 million less because of the reduction of the total pool size. So for the DSRIP budget 21, we are still expecting about a $25 million decrease from our current year level because it does not include the one-time granting of the federal matching percentage. So that's going to cost us about 14 million. And the interesting thing about DSRIP is it was only extended through the end of next year. We understand that HHSC continues to draft proposals to get approval from CMS to continue this program. So DSRIP will change that again. We've had about 3 separate rounds of DSRIP and how those funds are calculated. So there'll be more to come on that, I'm sure, during the year. So for a summary, I just this pie chart represents our total supplemental funding. In 2019, it was 125 million. In 2020, it's 244 million. And in budget 21, we're looking at 177 million. But you can see how it used to be pretty equally spread in 19, and with that large UC change with the formulas, how large the UC section has grown to over 20 and 21. There is a fourth program, and we don't call it supplemental funding necessarily. It doesn't hit in the same area of our financials. It actually is an increased payment through the Medicaid HMOs that administer the program for the state. We have been notified that we'll be getting a larger payment per patient. So it's up in the net patient revenue section of the budget, and we'll be receiving about a $10 million increase for those patients when they come through JPS.
Sharon, is that a different calculation, or is that because we do a much better job of coding and all that stuff that as a result we have we can identify sicker patients so they pay us more, or just different type of formula that they're using?
It's a different formula. It's not necessarily what you're talking about as quality or performance based. It's actually paid on a per claim. It's an addition per claim through HHSC, and this too is a very complex program. But HHSC pays the MCOs more PMPM, and then they pay the hospitals a higher rate as those patients go through the hospitals.
So this is still the traditional one, not the with the star rating and all that stuff yet, right?
Correct.
Okay.
Correct. This was the program that initially generated the conversations around the LPPF and the taxation that we do here locally in Tarrant County.
Oh, I see. Okay, thank you.
You bet. So that was the fund for supplemental funding. I know that that's a very dry conversation. They're 4 very separate programs, and they're all very complex, but they're representative of some large changes between 20 and 21. So I'll be happy to answer any further questions you may have on that.
Sharon, this is Steve. I mean, and I think this is a larger conversation, and maybe we can circle back to it. Obviously, these are a lot of additional dollars, and there's going to be some, I think, fairly involved conversations that this board will need to have with administration in terms of the use of those dollars. Some of them are, maybe one-time events, but it's a lot of money, and so the question will be, what's the appropriate use of them, considering the unique nature of some of them. So just kind of putting it on everyone's radar screen that there's going to be a big conversation about this that we as a board need to be prepared to have coming up. Is that fair?
It is fair. So as we move past this budget approval, that will be discussed, I imagine, before year end.
Hey, Steve, this is Trent. Do you see that being a finance specific discussion, or do you see that being a response to staff recommendations? How do you see that kind of playing out?
That's a really good question, Trent. I think to me it feels so much bigger than the finance committee. Some of it's very much strategic. So I think I don't know. It feels like it's above my pay grade. I think it would be something for us as an entire board to contemplate. To me, because it just has implications beyond just finance committee.
Yeah, I don't disagree. I think it's probably beyond all of our pay grades. But one thought, Robert, Sharon, may not like this, but I mean, one thought would be, as you look at these dollars relative to current capital needs, especially in light of the delay of the bond program, and with the eye toward not increasing the future fund for obvious reasons, would it be appropriate that when you have sort of some recommendations regarding how this is allocated between operations and capital, that you would bring it back to either finance or the board so that we could kind of take it in small bites? Because I can see this taking a huge amount of time if we don't do it iteratively in a manner that kind of gives us a chance to see where each building block's going.
I couldn't agree with you more, Trent, and I think that's exactly the case. And what lies before you all as board members and what lies before us as staff members are some key issues. It's the funding of personnel. It's trying to figure out what you do when you have a 25 to 30% reduction in patient base, but you want to retain the doctors that you currently have. You have the proverbial question of how long does COVID-19 last? What if we're having this very same discussion next year at this time? And the other questions that you have that we need to consider is issues such as telemedicine and where we would go with that whole aspect, knowing that the facility fee is going to be hampered by that, but yet the end user of all of our telemedicine efforts have been a very positive. You asked the question was asked of what kind of response are we getting from patients? It's been good. Also in a movement of patients moving from their house to here. In COVID-19, it's been emphasized that there's going to be a stay-at-home kind of philosophy, but for a lot of our patients, because of lack of a vehicle or lack of ability to even get anywhere or not even being on a transportation site to move them from point A to point B, I think we have big questions of how we change our budget to deal with these and how we use these monies. And I think it's going to be a shift for many of us, but we have key items of telemedicine to consider, how many times these payments are going to continue. We are certainly blessed by the fact that we've been rewarded and given some of these funds right now. It is really helping us, but we also have to think about the future. So I think, Trent, to your comment, it's going to be in phases, and you can't definitively do it all at once. But then, as you're going to see in a couple of the other comments that Sharon's going to make in the rest of her presentation, the challenges that we face with correctional health and the challenges we face with MHMR issues and public health, we want to be a really strong partner for our community in any collaborations that we have. And we want to provide the care we need to provide. But there is a limit to what we can afford. And there's a limit to how many inmates come in the front door and what's expected of JPS. And I think those are going to be some tough issues that we not only have to discuss amongst as board and staff, but also with our county commissioners and our county leaders as to what's best. So a lot of pressure points, but we're at least in a good position to debate those rather than the discussion we would have. And I know Trent, you and Roger and Reverend Emerson have faced this with cities. You're not going into this debate in a dire strait financially, trying to come up with things. You're at least trying to figure out where you place your money wisely, as opposed to we are hemorrhaging terribly. How do we do this?
Getting back a little bit to a prior slide, but when we were talking about, the COVID funds are to be used for COVID related expenses or lost revenues. My second bullet point here is that, we may want to look at the connection program, losses during the subsequent upcoming months because of the pent-up demand that may be coming with either the current connection patients or an increase of those connection patients, as well as the improved healthcare delivery, which could be a facility, it could be a new program. So those UC amounts would be a good discussion to have at a board level.
I would interject real quick. I just tell you, because I love complimenting staff and the staff that I get to work with and the people that I'm around. Suzanne is on vacation right now. She is traveling by car, which I strongly support. Again, a comment to the Wright brothers. I don't like those guys. So she's drove from Fort Worth, Texas to Portland, Oregon. And now she's driving back from Portland, Oregon, back home. So she's on vacation. And she just texted me from the side of the highway saying that Reverend Emerson is having problems getting a hold of some of the slides, and Leanne and Stacy are going to work on getting him that report. So I just want you to know how incredibly gifted the folks that I get to stand around are when you literally have a staff member on vacation on the side of the road telling us that Reverend Emerson does not have the slides he needs. So that's why I'm so lucky. So sorry, I didn't mean the digression, Sharon, but wanted to let folks know how powerful the people around me are.
Okay, so if there's no other questions about the supplemental funding, I just have one slide on our capital budget. It's capital doesn't get a whole lot of love during this whole budget process. It's much easier to balance the capital request than it is trying to coordinate $1 billion or $1.3 billion of expenses and the revenues and all the complexities that are going. But we do put quite a bit of effort into prioritization. It's been my philosophy over the last few years that we fund depreciation, which means that we try to replace the capital that is effectively used during that accounting period. Our projected depreciation is going to be about $38.5 million. So that's our pool size for capital. In the past, we have pulled out about 10 million of this to put into the future fund and some of the larger capital planning. And that's more from a cash flow standpoint to say we're going to set these monies aside so that when we do a large capital project, it doesn't eat up the entire $38.5 million of routine capital. Most of what's included in that routine capital, it's kind of three big areas. We have patient care equipment that most of it has anywhere from a 5 to a 7 year useful life. We have IT, which is not just the hardware and software, but it's actually the brains behind the EMR and all the connectivity that happens as we provide that patient care. And many of the smaller construction projects and repairs and maintenance that we have to make on the aging facilities that we have. So that's just a reminder that the capital will be discussed. We like to show you some of the larger items that come out as a priority for us, and you'll see more of a detail in a couple of weeks.
Sharon, on the capital piece, this is kind of something I've never paid a whole lot of attention to, honestly. Is there a formula by which administration just kind of thinks about, all right, here's how much we're going to devote to capital on any given year?
So for the last few years, it's kind of funding depreciation expense. So if you think about the utilization or amortization, which is an accounting term, but as all of the previous year's capital is spent and depreciated, I try to replace that amount and keeps our ratios looking strong when outside agencies come in to look. And it's also a discipline not to spend more than you can afford. And a quick and dirty back of the napkin, if we're breaking even on net income, that allows us from a cash flow standpoint to support that amount of expense.
So not spending more than you can afford. That's a concept that I still need to learn in my life. Thank you.
I think we all need a little bit more discipline. It's easier at work.
Share this detail. A lot of equipment depreciate quite fast lately. Mm-hmm. Are we still on the straight line, or can we qualify for the accelerated depreciation method yet? Or are we only using them?
We're still. You keep drawing me into these accounting conversations. I think you might be studying for your CPA. We have, it's a good question. And as hospitals, we used to have, we have a guide from the American Hospital Association that tells us all of the life of the medical equipment. And that is done on a straight line basis, which just means that it's equal throughout that piece of equipment's life. Mm-hmm. So we take, in most cases, a lot of our radiology or patient care monitors will be a 7-year life, for example. So we'll take an equal monthly expense for that.
Mm-hmm. But no, for the laptops and desktop and all that stuff, I mean, 7 become anchored by that.
Category. No, the laptops are done over 3 years. If they qualify for capital, right now they do not. So we don't capitalize anything that's less than $5,000.
Okay,
And that's the Medicare limit. So we just match to that. And as that number raises, we'll raise ours as well.
Sounds good. Thank you.
This is, two concerns. One, when you have a central plant, the building as old as ours is, pretty likely that depreciation expense isn't going to keep up with capital demand. And we all know that, and we've experienced that, especially through elevator knowledge over the last 2 years.
Mm-hmm.
My comment earlier was really toward this, and that is, at least for my purposes, I am not in favor of putting more money in the future fund, especially when we have a delayed bond program. We have what we already know are some dramatic capital needs because we're having to delay the bond program. I'm talking chillers, boilers, central plant. I mean, there's some of those things that at least as one board member's opinion, I would be more than happy to see you exceed the depreciation expense methodology when you start budgeting capital relative to two things. First of all, the additional dollars that we're going to realize that we can probably best realize through capital investment. And secondly, just from the perspective of the future fund, knowing that that fund has been and will continue to be a target, I would rather put the money into infrastructure that we know is necessary and needed. We've still got to buy land for another clinic. I don't know how long the bond program is going to be delayed, but I would like for us to at least consider a more aggressive approach on capital relative to this recommendation.
Okay.
I agree with you.
I agree with you. Yeah, I third that motion. And this isn't the time for this conversation, but have we had the formal discussion on pushing back the bond program? And do we have to do that? I mean, we obviously had a ton of support for that, and I would hate to lose that support along the way. This is the biggest, fear I had in city politics is we'd say, okay, we're going to go build a new library, and we go and do all the planning and whatever else. And then I know we've promised no tax increase to do this, but if we start building in 5 years and there's a tax increase because of operations, we've already shot ourselves in the foot. So I don't know if we've had the full conversation whether the bond program is on hold, if it's on hold for how long. But if we haven't had that conversation, I think we need to seriously sit down and evaluate that.
Roger, there have been no formal conversations with any of the county commissioners or the county judge. They're still in the process, as you well know, of looking at the project manager RFPs that they sort of stopped at the beginning of COVID-19. I think it's a very worthy discussion. To comment on lack of support or losing the confidence of the voters, my opinion is, and this is anecdotal and it's just one man's opinion, is that the voters saw in JPS something that they have established some trust with. I think they felt we were providing healthcare through the community in a manner that they appreciated. And I also think they are very concerned and were concerned and will be concerned about mental health and the challenges with mental health. To Trent's point, there's probably things that we can do. We can do inside our own organization with capital to move some of those issues that we face and tell the voters. I don't think the voters said, we demand JPS have a bond package. I think that strong support we got from the community said, we appreciate what you're doing. We don't think you're wasting our tax dollars. We'll provide you the bond capabilities to do more. And we certainly have an emphasis in mental health, and we want to look at that. So I think we can appease a lot of those concerns, rightly so, and better serve our community. And I think those discussions are ones that we as a board and we as staff should orchestrate and have in a very methodical, pragmatic way with our elected officials at the county. And I think they would appreciate that open dialogue as well.
Robert, this is Zim.
Okay, go ahead, Zim.
Well, I was just going to tag on to this. I think right now the bond program is going to get a pass as far as support is concerned. I do agree that we probably need to start making some periodic discussion with our constituents about what we're doing and how we're doing it. I further believe that even with the capital as well as the bond program, I think we need to go back and look now because our business model is changing. The physical plants may look different now. There's a whole lot of stuff that we don't really understand right now that's going to affect both capital and bonds. I think the city right now is trying to decide whether to make another tax cut or not. And I'm pretty sure that is not going to happen, although some members of the council want it to happen. Don't know what Tarrant County is doing in that regard. I do know that Fort Worth ISD is getting ready to come back in and ask for probably a fairly large tax hike. So between not getting a decrease in the city taxes and getting an increase in the school taxes, we're probably going to be able to fly under the radar a bit right now.
Well, I think your points are well made, Zim, and I appreciate it. It is a little bit challenging to see your screen come up as Winton Zimmerman, so I'm going to continue to call you Zim.
I asked David to make a change on that, and I guess he lost that note.
Yeah, well, I think David said, no, I'm not going to do that. I want to call him Winton. But I think your points are well taken, and I think that there should be dialogue, but I really appreciate your comment, Zim, about our business model has changed. One of the things that COVID-19 has shown us is the need to go where patients are, not to build the biggest bed facility you can possibly build. I think that our friends to the east at Parkland are still going to be challenged with what they built in their last bond election with an emphasis on beds. And I think we could learn a lot, not only by COVID-19, but where healthcare is going from a standpoint of getting to people rather than housing them. Now, we do need more bed space. I don't deny that. But I think we need to go back and look and say, do we need as much as we originally thought 3 years ago and 4 years ago? That will be really critical for us. So, Zim, points well taken. Roger, I knew you had a point to follow up.
Well, in honor of Disney Plus and watching Hamilton, I don't want to miss our shot on the bond issue. I mean, I know COVID, basically put the world in paralysis, but I think it's important that we continue to invest in the physical plant and that we continue to bite off, even if it's just the small chunks, even if it's the ambulatory surgery, even if it's the 2 medical homes, even if it's something for mental health in smaller chunks and not do 800 million at once. And maybe even pulling those smaller centers out of the grand vision plan that this consultant or construction manager is going to do. We can handle those things ourselves. And I completely agree with Trent that we can't just simply pay for what we depreciate, because a lot of it's already depreciated.
Yeah, no, I totally agree, and I appreciate y'all's comments. They're hugely helpful to us. I will tell you that the feelings that y'all just expressed are very similar to the feelings that we have begun to talk about within staff as well. So we're all kind of getting to the same page. I hope that our partners in the elected side will see some of those same things, and I think they will. And Roger, I'm very pleased that you're quoting Hamilton and not Frozen 2. So thank you very much.
That comes at the end of the presentation.
Well, let's hurry up and get Sharon to end then. I want to hear quotes from Frozen and possibly even a dance. So other questions or comments that y'all have at this point?
Robert,
Sharon's got more of a presentation.
There's a lot of board members who wish I would just quote "Let it go."
Well, we do appreciate it. Thank you very much.
Did he say let it go, or that we want him to go?
No. I'm gonna leave that interpretation to y'all. Sharon, why don't you continue on with your comments?
So, again, focusing on the budget in a couple of weeks, the significance of this slide was to potentially generate some conversation around the historical future fund contribution. And if it is the consensus of the board, we can take that direction for the 13th presentation.
I will add my voice to that. That I really do want us to see, not necessarily put more in the future fund. I concur with what Trent and Roger have said.
Okay, so we will, as a staff, go back and take those comments under advisement. So we'll have a more complete presentation for you on the 13th. Okay, I could not have asked for a better segue from Zim on ad valorem tax revenue. Before we get into a slide, I will just say that, you know, ad valorem taxes have been a discussion for very different reasons in prior years because of the amount of the additional revenue, because of the larger tax base that we benefited from the growth in Tarrant County. This year looks very different. And as we move through the slides, the one right after this, you will start to see from the budget right now, the number that you're going to look at is based on, from the Tarrant Appraisal District, the June estimated tax roll. They take into account the total appraisal values that are sent out, plus a factor for what they know to be under appeals. So just a little tidbit of information, every $1 billion in taxable value is worth just over $2 million for JPS. So this is a 5-year look back on what has happened with our tax revenues. You know, we've had a nice significant increase, as I mentioned earlier, anywhere between $30 and $47 million, most recently between 19 and 20. It's holding steady between 20 and 21 for many different reasons, but there are a large number of appeals that are currently in process. So again, we may receive a certified number as early as this afternoon, but it is due next week, and we will be able to kind of lock that number in. As I discussed yesterday, even though we get a certified number, that is not a guarantee of the taxes that will be received. We've had some negative adjustments to that certified tax roll throughout this year because of the number of appeals that were won by the property owner. So with some of the larger increases that we've gotten and patient payments that we talked about earlier in my presentation, along with some of the supplemental funding, we are not going to project at this point in time, unless the numbers are very different. We actually called them this week and they were sticking with their June estimate. So this is the latest information that we have today.
Sharon, I can't see that number. What is it?
We are going to be getting about $1 million increase from our 2020 projected amount based on the June estimate. So our total tax revenue is just under $460 million for budget 21, or $1 million increase. Okay. Last year we got a $47 million increase.
But before Sharon goes into the next slides, I will tell you that from the history of some of this, when Trent was chair, we really took a deep dive into public health and what we were doing and how we were doing it. Sharon will go into a bit of detail about the relationship we have with correctional health and the difference between correctional health that we supply to the county and the correctional health services or the health services we provide to the federal prison. So you've got 3 buckets that have been problematic and challenging at times: MHMR, public health, and correctional health. One of our biggest challenges, and this is where we need to have very essential and collective dialogue with our county commissioners and our judge is what's happening at Correctional Health and how we can continue to afford such expenditures, and how we need to probably communicate the best way to provide correctional health. And it may not be in the future with JPS. One of the things that may be considered is from a standpoint of being efficient with county funds and providing the healthcare you need, maybe there's the possibility of an RFP to look and see exactly what the county is getting and the best services for the county and who can deliver those the best way possible. When we look at the public health department, Amanda and I have had discussions. Some of you all have had discussions with me. Now that we see a pandemic and we see the clinical need for public health, and I know Dr. Weber has discussed this with me as well, is there a greater role that JPS should be playing from a clinical standpoint to help the county and to help our residents and be of service? So what we're going to discuss next are some of the challenges that you all as board members need to begin to think about. That's why this is not a line-by-line type discussion. This is a philosophic discussion about where we go and what we do and how we have discussions with our partners in the business. So Sharon, if you don't mind, and Sharon's back on now because she's not frozen looking at herself. So she is much better. So we'll continue on now with what we know are going to be tough subjects, but we want to place those seeds for you all to figure out where we plant them and what we do.
Okay, so my purpose here today is to kind of review for you again a budgetary impact of these programs, and to do a little bit of education because it is confusing how federal inmates and county prisoners make it through our system. They're two very different populations, but we do fully fund the public health initiative here in Tarrant County. This is actually a county agency, but just to kind of show you at the top half of the page, they've had about a good 3% inflationary increase in request through the last 5 years. They have, most of that is in salaries. It currently for 20, it was 12 million, and for 21, they've requested 12.4 million. The second part of the county funding is with the jail. MHMR is subcontracted to provide kind of the initial assessments of the county inmates that are at the Tarrant County facilities, and there's a handful. That you can see is increasing year over year, fairly significant increases in 19 and 20 of 13% and 15%. Last year, the expense was 3.9 million. A lot of those increases are due to, and we have had conversations at the board level about magistrate changes and policy changes, legislative changes that are rolling through and required some increased staffing because of increased inmate populations in Tarrant County. So those are actually recorded in our financial statement and other expenses. It's one of the larger components of that line item. Again, 12.4 million for public health and 3.9 million from MHMR. I will note that there's a 0% increase for fiscal year 21 for MHMR. We have confirmed through Tarrant County that no additional dollars would be requested through 21. So I tried to make sure this was their final numbers before this presentation today. So we have those two pass-through expenses, and then we also have inmate populations. And there was some discussion a couple of meetings ago, and I just wanted to clarify how the federal prisoners make it into our system and we receive payment. and the difference when we see a Tarrant County inmate from the Tarrant County Jail. So from a prison standpoint, the health care is actually managed by the UNT Health Science Center. And JPS is the preferred facility for inpatient and specialty services. UNT provides primary care at prison clinics on site when they can. And if they need a higher level of care, we contract with UNT Health Science Center just like we would a managed care payer, and we receive a per claim payment like we would from a commercial insurer, taking into account the severity of the patient as well as any services that were provided while they're here. On the other hand, JPS has been tasked to provide services for the inmate population, and we do not receive a per patient reimbursement. And of course, if we're not receiving that, we're not taking into account the severity, the volume, or any other considerations. JPS provides the on-site clinics at the Tarrant County jails. So the prisons are separate. The Tarrant County Jail is what we were going to focus on the next slide. So the county inmate population, these are some direct costs of care. Because of some of the magistrate and legislative policy changes that occur at the county level, we have seen those costs increase about 53% over 17 to 2019. And a lot of that factor has to do with the average monthly intakes of the jail inmates. The total spend from an inpatient, and we'll cover these in the next sentence here, but they've increased about 38%, and we would expect those to continue to increase with number of jail inmates. So our on-site jail clinics are departments within the hospital, and we spend about $20 million a year on those on-site at the county jail clinic. Oftentimes, those inmates, as their illness progresses, require inpatient stays. That is estimated around $8 million a year, as well as outpatient and ancillary care for specialty visits of about another $1.5 million. And then we talked about a couple of slides back, the jail MHMR mental health contract that passes through for about $4 million.
Sharon, do any of those, I think I know the answer to this, but I'll ask it anyway. Do any of those inmates have qualified for any other payers, Medicaid, or anything like that?
Not as inmates. They do not.
So when they become inmates, they're not eligible for Medicaid?
That is correct, because the jail service itself is required to provide that care.
Got it.
So they effectively have coverage at that time. So that is, we currently are working through a lot of contractual issues, and there is quite a few of us that are working to get a more concise contract around the inmate population itself. But for the budget in a couple of weeks, we have carried forward these costs.
Hey, Sharon, how about, what is the rough estimate of the number of patients that you're seeing at Correctional Health? I know we do the initial screening of every inmate that comes in, but what is the number of, do you know the number of patients that actually have additional services or need additional stays?
I don't have those numbers in front of me, but I will be happy to send you an email after the meeting to make sure that we have those. It's pretty straightforward when you look at the clinics, because like I said, those are easy enough, but we do have numbers of screenings and total inmate populations. The peanut gallery, who always has my back, is texting. It's about 5,000 inmates per month.
5,000.
5,000. Yeah.
Okay.
And the challenge, Amanda, that we have, and Sharon may have gone through this, but the challenge that we have is the jail sometimes doesn't understand the population and its increases. Because what the jail is going to look at is not so many who's in the front door coming in, but what's their population on the daily census, and what can they move on and move to other places or rearrange. Our challenge is those numbers don't matter because every inmate has to be screened. So if they have an increase of 2,000 inmates, that's a huge challenge for us from a nursing standpoint and what we have to review. So we've had those discussions with them. The county jail decided to take on more city inmates from Mansfield and other facilities throughout the county. That's fine. That is a policy decision of the jail. But when we have to staff 5, 6, 7, 10, and 12 more nurses to accommodate that and increase medical staff to deal with an influx of 2,000 more inmates, that gets difficult. And we're not part of the discussions on any increases they see. They're really vexed right now because the state has pretty much stopped taking transfers from county facilities to state facilities because they're getting full at the state levels. That's what we faced in the mid-'80s in Texas when William Wayne Justice moved in and said, you got to build more prisons. So it's a little bit of a logjam, but our biggest problem is nobody asks us about personnel needs, and we get hit really hard because we can't say, oh, okay, well, we're not going to see 10% of you inmates that came through the front door. We have to medically screen everyone.
So is that the number of screenings, about the average of screenings of 5,000, or is that the 5,000 number of additional care?
Those are total screenings.
Total number intakes. Yeah.
Yeah, those are intakes.
Which on a month basis. Yeah. Yeah. And so I know that last budgeting cycle, we added additional nursing staff. Can y'all remind me of the number of nursing staff during that particular time? I think it was it 14?
I was going to say about 13 or 14.
Yeah. I had 12 in my head, but y'all are probably right with 14. And I think that's right. And again, we did not do that and go back to the county and say, county, we need the additional funds for 14 nurses. It's unfortunately become expected that that's what we're going to do. And we have to be fair to them and say, we can't continue to do that. That's why there may be better ways for them to provide correctional health other than what we can afford.
Correct. Yeah. And Amanda, the chronicity and the acuity that we're seeing in the jail continues to increase to be much higher, much like we see here at the hospital. We really would like to take care of them at the jail, but because of our needs for additional staffing, we've had to move many of them here to the hospital. And so, in order to maintain safety there and high quality care that's comparable to what they would receive here at JPS, we have not had the additional nursing and pharmacy needs that we truly need out there in order to support the increased number of inmates that are now being seen there. So it is a real challenge.
Oh, absolutely. So out of this 8.1 million, how many patient days do y'all think that would be for inmates?
Amanda, I would have to get back with you on that. We obviously have the information in the detailed file. I just did not get that number.
Oh, that's fine. That's fine. Thank you. I know that this is a huge challenge. So,
and we don't want to shortchange the county, and at the same time, it does have significant impacts to the care we're going to deliver to other patients that are here at the hospital. And to Karen's point, we can't take care of as many down in the clinic at the jail setting, and we have to bring them here to the hospital. And it is very, very challenging. I think we all need to admit where our numbers are going.
And I think it also, I mean, this all stems from social determinants of health too, as well as the level of severity of illnesses that are coming in to the jails. So they're probably not getting screened or seeing doctors before. This is a total assumption. And when they come into the jail system, you're able to find those things and treat. So, I mean, it's a heavy burden on both sides.
Well, and particularly for a mental health patient, where you have a mental health patient that is picked up on a misdemeanor offense and taken to the county jail, and the time that they're going to stay at the county jail, and what we need to look for in either diverting that population and the role JPS plays in that diversion, and what we do for the finances to pay for that. But there is definitely a significant need, and I think we all need to have clarity in our discussions.
Hey, Robert, this is Trent. One other just comment to add to the equation is that the jail would like nothing better than for us to go spend 20 or 30 million dollars and give them all the capital room and all the capital equipment and everything in the world they'd like to have to be able to treat patients, which would avoid them coming to us. But it's not a solution. It makes the situation even worse. So I like the track that Robert's on, and I'm not sure that we don't even integrate FQHC into that discussion at some point relative to how better to treat the prison populations. But to the extent that we can put together a persuasive argument that contracts this out much more efficiently and with less stress and cost to us, I think that's the way to do it. I do not want us to go spending more capital in jail.
Totally agree.
Yeah, we couldn't applaud more for that. And also, we got to think about the best care for that inmate population and the population as a whole. And there may be others that can do this in either a more efficient manner or a safer manner or a better manner. I just know at this point, we're getting into challenges that are difficult for the inmates, difficult for the jail, and difficult for us. There is not a win category right now, and I think we could make it a win with a few adjustments. Thanks, Trent. I appreciate the comments.
Yeah, and just to add one more fact, Zelia just texted me that since 2018, we've added 38 FTEs without any increase in dollars from the county. So it'll continue to escalate.
Yeah, I agree with Trent.
Trent, a lot of your comments today are receiving huge approvals from us as staff.
They really
are.
are.
You are on a significant roll today. I think you should keep it up.
Yeah, you just made my day, Trent. I can tell you.
12 hours yesterday practicing, Robert. I'm learning how to do this. It's leading up.
Right, you're doing a great job. And I tell you, after you finish your 30th year on the board, you're going to have it down pat. And I appreciate it.
Robert, this is
Yes,
Dorothy. Even if the county does not want to contract it out, would we have any right to contract it out because we're paying for the service?
It would be a challenge to do
it's
it.
Probably not
way.
the best thing. I mean, because then we'd have to manage the vendor that we contracted it out. We'd probably get a very, low rate, but then we'd have to oversee the quality of care. And I think that would just be very difficult for us to manage.
Well, whoever
a subcontractor.
Okay, but even if the county contracts it out, you're still going to be paying for it, and so you're going to be overseeing it anyway. So I was just trying to figure out if they decide.
I'm not sure we'd see the day.
Would it be? But I'm with y'all for whatever you're trying to do. Okay.
I mean, there is a belief, Dorothy, that if they contract it out, the county should assume the aspects of that. And the other thing, the reason that is smart is if we contract it out ourselves, we're still going to be in that really difficult position of not having decisions being made by the medical side and being made by the jail side. And all of a sudden the costs go up and we don't know about it. If they own the contract, they can work with their vendor. They'll have, in my opinion, far better care, and they can have the dialogue between the two. If they own that contract and it's actually paid for by, you see X amount of inmates, you're paid X amount. There you go.
Right.
And I think part of how it was established years ago, I mean, this relationship with the county was established 25 years ago or 30 years ago. And I think it's probably time to definitely revisit where it is. So, and Dorothy, I appreciate your input because you saw it when you were chief nurse here and you knew some of the challenges with correctional health.
Correct. And my other question is, there are other public hospitals that's doing what we are doing, and what is their setup? Do we have any information on that? Because I believe that this is a county responsibility and they should be paying for services because they're getting money from the government too to help pay for this. So I agree that they need to be paying for the service. Okay.
Yeah, we have colleagues. Take Houston for example. Houston does not do correctional health for Harris County, and I believe there are quite a few. I don't think that Bexar County in San Antonio has a correctional health program as well. El Paso just started, but theirs is a little bit different. And well, I think it will be helpful if we look at the comparisons of what some of the other public hospitals do. Yeah. But I know that none, from the talking that I've had with my colleagues, none of them do it like we do, in that sense that you just provide all the care and your increases go up all the time. That no one has that relationship.
Yeah, I would think so, and I would think that we have. Is this, they say we're doing it because they say it's a legal responsibility and we've just accepted that? Because I don't think that's true because they are an entity too.
Yes, ma'am. Yeah,
Okay.
I don't know what they claimed or what the issue is. I said, but way before my time. But I think, again, I'm a big believer in if we have the proper dialogue and people see what's going on, people want the best healthcare for the inmates. Right. And I think we can do that, but I think there has to be a realistic look. And this is coming to a head mainly because of the significant increased cost. To Amanda's point, we added 14 to 16 more last year. How many more are we going to add this year? How many more next year? You can't continue to do that. That is not a business model that can sustain itself.
I agree.
Super. All right, Sharon.
So, Amanda, to your question, we saw about 3,100 patient days related to that 8.1 million of inpatient cost.
Wow. Okay. Thank you.
You're welcome. So the last slide is just actually my wrap up. We did a lot better today than we did last Friday. So, the approved operational budget, I've mentioned August 13th several times. We will be taking that afternoon to go over and request approval for our 2021 budget. The presentations are usually mailed out no later than the Friday before that Thursday meeting. And then, as in years past, I will plan some dedicated time where you can give me a call or you can call me anytime outside that dedicated time. But you will have access for questions as you review that budget. And honestly, I welcome your questions. It gives me a chance to actually kind of go in and dig a little bit deeper. And if you have the question, I can incorporate that into the presentation on the 13th. I can add a slide or two based on some feedback that I get from you as board members.
What we'd like to do now is I want to emphasize that what we've done in the past, and I think we'll be even more effective about it this year, is allowing Sharon to answer some of y'all's individual questions. So Sharon will make herself available during business hours or times that you need. And if you can't make that, I'm sure we can make accommodations. Although she has two boys, most of her life seems to be, especially this time of year, really dedicated to this. And I appreciate that time and effort. But our goal was to give you insights into the process, but Amanda and Zim and some of you that have come onto the board, even Dr. Simmons, if you all have questions, if you have concerns, if you want to know more, Sharon is available for that. The team's available for that. But I do think this budget process and what we're going to discuss on the August 13th meeting is really some critical decisions we need to make about the future of where our budget goes and what you deal with issues like correctional health and where we go with bond and where we place monies that we've been fortunate enough to receive. And to Sharon's point, some of the federal reimbursement dollars, I want to emphasize again, some of the federal reimbursement dollars we've got might look like big dollars, but that's compounded by the fact that we've had 7 years of cuts from federal reimbursement dollars. And you all as board members know that for the past 4 years, 1 to 2 weeks after we passed the budget, we were notified that you're going to take a $10 million hit one year. We took a $7 million hit the next year. So we've really been faced with some really hard situations. We don't face those this year. So we need to be smart with how we do things. So our hope as staff is that you all will go through this slide deck. You'll go through the information that Sharon has provided you. It'll generate questions, but more importantly, it will generate y'all's philosophy. We heard a little bit of that today, and that will be helpful for us. So, Mr. Montgomery, I will definitely turn it over to you and thank you. I know that you've requested another meeting just like this for Sunday afternoon. I think the staff might want to delay that. So it's all yours.
Thank you. Thank you to my colleagues for your time and your attention and your energies. I think that we were able to give some qualitative feedback to the administration. And like Robert said, there'll be opportunities for more of that. Thank you to the staff for all the work that went into putting this together and the information you're sharing. I think it's helpful for all of us. Mr. Chairman, I have no further comments on my end. Any wrap up you'd like to make?
I have one question, and that is when she was discussing the capital budget, if she might comment on the expression that she used, quick and dirty on the back of the napkin.
You know, that's how all good reasonableness tests are done.
No, I have no comments, Steve. Well done. Looking forward to the next step.
Very well done.
Steve, Trent, hey, thanks for doing this. This was an inspired idea. And honestly, this was really, really good. It was well done. Staff did a great job presenting it. I've been on this board a long time, and honestly, this has been some of the most productive discussions we've ever had. So congratulations and good job.
Thank you. Thank you.
Good, great job.
All right, I think with that. Good job, Charlie. With that, Mr. Chairman, I have no further comments. I think we can let these hostages go for the weekend.
Got
it. Thank you all.
Thank you. Bye-bye.
Bye.
Have a great weekend.
Yeah.